and welcome to Cocoa Pods, a podcast of the Broad Center for Natural Deliveries Foundation. My name is Dr. Bola Sagade. I'm the host of this show. Today, we're very fortunate to have with us Dr. Mary Joy Weathersby, MD, FACOG. Your conversation brings up two important topics. So the first one is, how is the American College of OBGYN helping us prevent that first C-section that can, lead to problems? So how can we prevent that first C-section? And then number two is that there is disparity in the number of cesarean sections being performed in minority women, in Black women. And there is actually a reason behind this that has been proven by studies. And the third thing that your recent conversation is bringing up is breastfeeding. And I want us to talk about that quickly, because that's the simplest of all these three things. The moms of C-sections have a lag in their peak production of breast milk after a cesarean section. And, what can you tell us about that?
It's not an easy thing because it is, the certain parts of the C-section is just sterile. And so there's certain things you just can't do. You just, you're not able to latch on immediately after delivery, as you are more easily able to do after a vaginal delivery. But we tried to make it a bit sooner, if you will, after the mother's in recovery. And after the mother is monitored and making sure that mother is actually stable, and mother decides that, yes, I want to try. And this is also making sure baby in nursery is also stable. We've got two components to make sure that peds say that baby is stable. And yes, let's go for let's go for mother to begin breastfeeding. But you have you have about a good hour from delivery, like with the C-section versus vaginal delivery. The vaginal delivery, you have a few minutes if everything is going very smoothly and well, and mother decides, yes, I'm ready, I want to go ahead and breastfeed, and nursery has evaluated baby and baby as well. Nursery evaluates baby in the room with vaginal deliveries, and NICU and nursery evaluates baby in the OR with C-sections. And then when baby goes to the nursery area, they also evaluate baby in nursery area also with C-sections. So you've got a much shorter time period where that can occur if mother decides. Now, some vaginal delivery, some patients decide that they want to just go ahead straight to formula and go in that direction, or some decide they want to try. So there is a lag, but only because of what it is, it's a little bit difficult to take that away, because it's still a section, and it's still sterile, and it still needs to be sterile, and still needs to complete mother's care, so that mother can then do bonding and breastfeeding with baby.
Thank you. All right. So, the current recommendations by the American College of OBGYN on C-section is that they still prefer a vaginal delivery when possible. And then they want you to do a C-section when needed, as per the doctor's recommendation. But the college is also doing an initiative now in which we want to reduce that first C-section. They're telling doctors to do things that will reduce that first elective C-section, because once you have that first C-section, there's a chance of having another C-section. How can we what are the barriers? Why can't that first C-section rate fall? Why can't it decrease? Or what is happening with that initiative?
It's a good question, but it's a little bit difficult, and I think that's something that most definitely OBGYNs do strive to not do that first C-section if possible. But sometimes the C-section, you may not have another option. But that primary C-section elective, ACOG does say that a patient can elect an elective C-section just because she wants it. And so that's also difficult in the same setting that ACOG does say that. And I do definitely try to counsel a few patients that have actually wanted that. I do try to counsel what that means, what that could potentially mean in the future, and the reasons behind that. Definitely pain should never be a reason for that. And I definitely counsel patients on that there's many different pain management methods and options that the patient has that she can go through without having that. And in terms of having that initial C-section, I feel as though many times I want to say all OBGYNs, but I don't know all OBGYNs. So I am limited to not say something like all OBGYNs, but definitely the ideal amongst, at least most OBGYNs is that we don't want to do a C-section unless we need to do a C-section. And we do have what's called a labor curve. We all know that many women totally fall short of the labor curve, meaning they have long passed the labor curve, meaning if you're supposed to be at this level by this many hours and by this, we have things of that nature. But many of us don't necessarily, use that so stringently. What we do is give the woman additional time and make sure that the woman feels comfortable. And we do this as long as the tracing is good, as long as the baby is tolerating labor, as long as mother's tolerating labor. But we all know that there is a certain time limit still because infection does come in, and we do worry about infection, and we do know that infection can be more risk for the baby and also risk for mother. So there's a time where the risk of infection becomes too great and mother is not progressing, that we don't have another option. We only deliver one of two ways. If it's not happening vaginally, then it needs to happen surgically. And then there's the times where the tracing is not category 1 and not even category 2.
The tracing is when we have the mother connected to a monitor to give the tracing of the fetal heart rate. And based on how we OBGYNs interpret the fetal heart rate, we can call it a category 1, which is good, a category 3, which is bad, go for a C-section, or a category 2, which is in between, I could watch you or do something else, right?
Mm-hmm. Correct. And category 2, you definitely want to intervene. And oftentimes what happens is you can intervene and it has good recovery. And then you try again and perhaps you get that persistently. And you get that persistently with no cervical change. And there's, again, a time limit. There's a time frame of how much distress do you put the baby in? Do you allow the baby to continue to be in without showing actual cervical progress? And these are conversations you have with the patient and with the patient's family. And these are conversations definitely that are worth having. We can stop the Pitocin for a moment and let baby recover. And then we're going to restart the Pitocin at a lower dose, even half the dose, or restart altogether at the first level and see how baby does. And if baby does well, it allows mothers to still progress and we could continue. Mother has no fever, baby's not tachycardic, and tracing is tolerating it, you can continue to recover. But if you're getting persistent late decelerations, these are not good decelerations. These are decelerations letting us know that baby is not necessarily tolerated labor. if you're in that scenario, you do need to intervene, because you need to actually listen to the baby, and baby has few ways of communicating with us, and the tracing is one of them, to let us kind of know, hey, this is something that we need to do. Now, of course, you have your emergencies where there's a cord prolapse. Well, that's just an absolute emergency. You go immediately and do a C-section, for that cord prolapse. You're not able, that's the ACOG response for that. That's the response. That's what needs to be done. So the idea is definitely there to try vaginal. And I'll tell my patients, we do desire a vaginal delivery. Definitely. That would be great for everybody to have a vaginal delivery. But that's not reality. Reality doesn't give us that. And so we have to go with what reality gives us. And it's a little bit of kind of, we deal with what's presented, and not necessarily, it's very difficult to make something, that usually is not the direction it happens. It's usually something happens. And so we have to respond accordingly and kind of say, okay, well, baby is tolerated, baby is happy. Mother, we can watch you another few hours and kind of see 2 to 4 more hours and see if you're, making any changes, and keep going as long as we're doing well. If we're not doing well, we do need to talk. Okay, this is what's going on. And of course, the internal monitors are absolutely helpful. The ISC, when you're by guidelines able to place it. There are certain situations where you're not able to place an ISC. And then an IUPC also, when that's able to be placed, that also definitely helps you to understand not just that she's contracting, but, these are the strengths of the contraction. And this is, we are now adequate. We have enough of the Pitocin, or we have enough, of power, if you will, for that. And so maybe it's more of a passenger. Maybe baby is not able to fit through the pelvis, or maybe it's not, or maybe it has nothing to do with that. It's just the baby is just not tolerating the labor course, and we need to intervene.
No, thank you. So we're now at the critical question of this podcast. Why is it that Black women and some other minorities in the United States have more cesarean sections than white women?
That's a very good question. And it kind of leads me going right back to the article that I read, and I'm very sure was on Serena Williams, as high profile and celebrity and amazing accomplishments and just fantastic achievements, still was felt to not have been listened to by her doctors. And oftentimes, I think that's where it all begins. You hear me talk a lot about the conversations that I have with patients. It's an interaction with myself and my patients. We want to talk and say, okay, this is how it's going. This is my expectation, your expectation. This is the medical reasons why. There's a lot of conversation that goes in the care. And that's the way it needs to be with every single patient. And oftentimes you do read about minority patients being felt that they're not listened to, they're not taken seriously, their concerns are not heard, and that should not be. When you're interacting and you're saying, okay, well, I would like to, try a little bit longer and have this delivery and try that, it can be done, but it must be done with a willing participant to listen, to interact, to discuss, and to actually say the reasons why. Okay, well, here's the reasons why. As a doctor, perhaps I feel as though we should do it this way. There's nothing wrong with your doctor saying, okay, here's the reasons why. This is what the guidelines tells us. This is what the medical literature tells us, not just Google, please be careful, not just doing a bunch of Google, but this is what medical literature actually tells us. This is what we've learned as medical OBGYN guidelines and such. And here's where the doctor is coming from. And then the patient can say, okay, well, this is where I'm coming from. The interaction, being heard, being communicated, being listened to goes a long way in understanding. And then also in educating and in teaching. I love to educate my patients. I love to teach my patients. And what I'm teaching, what I'm educating on is the medical reasons for it, the medical interventions. Not just, I'm going to do this is how it's going to be and that, but it's a total involvement of the patient with me in their care. So I'm sharing with you, I'm teaching you, this is why we do this. This is the reason why this is happening. This is the reason why that, so that you understand what's going on and why it's going on. And then you can also share with me, well, I would like this. Okay, well, we can do this, but you know what? Medically speaking, we're not able to do this. And this is the reason why we're not able to do it. Sometimes there may be an actual medical reason to do something, but it's not communicated with the patient. And the patient is slighted and they're not sure why they're even having something done. They're not even sure what was done. And that's unfortunate. And that is not good medicine. Actually, you want to be a good patient advocate for your patients. You want to talk with them, communicate, and let them know every step of the way what's going on, why it's going on, your input in it, and listen to their input in it.
Wow. So there's also, in addition to just, a lot of academic literature out there and personal experiences from speaking to women, minority women, there is data that show that not only are the women not listened to and their concern not validated, or they're not, situations are not expressed to them in a language or a manner in which they can understand. There is also money involved. And it shows that US hospitals charge an average of about $22,000 for a C-section compared to about $12,000 for a quote unquote normal uncomplicated delivery. And also that in 2010, with the Affordable Care Act, that meant that more Black women had medical insurance than before, but it did not remove the profit motive from hospitals. And that just meant that there was more incentive then for the hospitals to push women down the profitable path, knowing then that their insurance company can pay and will pay. And so there's the issue of the women not being listened to or validated, but then there's also the issue of money and profit in the United States.
And that is, profit often drives a lot of things. That is unfortunate. I think that's incredibly unfortunate. The biggest thing that you want to do as a doctor is to be your patient's advocate and to do your very best for each and every patient, and to listen to your patients.
So, Dr. Mary Joy, thank you so much for this. The joy of a newborn's face, often blurs the trauma of childbirth. And, so regardless of the route of delivery that we ultimately offer our patients, like you said, we want a good outcome of mothers, of babies. We want less women, period, minority or non-minority, facing issues of maternal morbidity and maternal mortality from childbirth issues. And so before we close, number one, I want to thank you so much for coming on the podcast. You have been recovering from a cold, and because of your busy schedule, you decided to honor your time commitment to this time of for your podcast. So number one, I just want to thank you very much for the knowledge that you have imparted to women all over the world concerning such an important topic as a cesarean section. But in closing, what parting words would you like to leave with our listeners today?
Well, I definitely am grateful that you even have the podcast, that you invited me on. Thank you for this. Thank you for all that you do also. You do quite a lot for all of your patients, and very happy to be here. And I definitely want you to continue doing all of that. For patients all around, I want them to know that they deserve to be heard, that they're not an inconvenience in any way, that they are important and they are very special. And I do want them to come in with their desires, but also I do want them to listen to, because sometimes we do have our desires or certain ways that perhaps we may want delivery to go. And we definitely hope for it to be that way. But sometimes there are medical reasons for doing things. But if you don't understand, or if it's not being communicated, just say, but why? Or what is the medical reason? Or what, and hopefully you're going to come across a doctor who is also a patient advocate, a doctor that's going to sit and take the time to explain it and explain it in a way that it can be understood. Sometimes, make it perhaps using analogies instead to make the situation more understandable. But this is where you're talking to your doctor throughout your whole pregnancy. I want you to come in and see your doctor as early as you can in your pregnancy, as early as possible, and just kind of share your thoughts, listen to their thoughts, and keep going back and forth. Hopefully you'll find that right doctor that's going to listen to you and that's going to honor you, and that you're going to have a good relationship with. Your doctor's not necessarily a genie that, does all that. That's not reality, because it's not medicine. There's reasons for doing certain things and not doing certain things, but it is a relationship that, this is what your doctor expects and this is what you expect. And this is, what we can do and what's what is medically safe, what is medically better, and certain options and such. I definitely want you to strive for that, and to know that you deserve it, and to know that it is achievable. I think several patients have asked me, is it still exciting? Is it still amazing, the deliveries? And I can't even tell you how many I've done. Definitely thousands. I don't even know what number I am at the moment. It's many, many. But each and every one there, it's still awesome. It still is a joy. It still makes me smile. It's still beautiful. Every single delivery that I still do, it's still awesome. I'm still like, oh, I love this. It's still an awesome thing. So yes. It's a great thing. It's a great joy. And I definitely hope all the best to all the patients, to everybody who's listening. I hope you definitely got something good out of it. And I hope you continue. And I wish you all the best throughout.
Well, Dr. Mary Joy, and hence your name, Mary Joy. Thank you. Board certified obstetrician, gynecologist. You come from a position of authority. You've done several thousand C-sections yourself. You're a mother, you're a wife, you're a good friend, and a very passionate patient advocate. So thank you so much for your time on Cocoa Pod's podcast today. Thank you.
Thank you.